Hi, welcome. We're so happy that you're here to hear Dr. Akor talk about eye injuries for attorneys. Next slide, please. I'm Amy Fogelman, and I'm honored to be here as the founder and CEO of High Rock Experts. I've dedicated over 2 decades to caring for patients within Harvard-affiliated practices in the Boston area. And that journey led me to creating High Rock Experts, and it began with this core mission to provide ethical and credible expert reviews. Since our inception in 2018, we've successfully matched over 550 medical experts with attorneys across the United States, delivering reliable support to the legal community. In 2020, we took our commitment a step further by creating High Rock Academy. This platform is designed to empower medical professionals with the skills needed to become credible experts themselves. And today we have the privilege of introducing you to one of our Academy graduates, Dr. Charlotte Akor, who will share her insights with you shortly. Next slide, please. So let's go over to briefly talk about today's agenda. After the presentation, we will have time for questions, and I want to encourage you to make the most of this opportunity. So if you have any questions, feel free to include them in the question and answer form. The chat is disabled, but you want to put it in the Q&A form at the bottom of your screen. And both Dr. Akor and I will be available to answer your questions during that session. And then finally, I want to make sure that you stay at the end of the presentation so that you receive the special bonuses that I will be sharing with you. So let's move on to our main event. I am pleased to welcome Dr. Akor. Dr. Akor is a Yale-educated ophthalmologist with 17 years of clinical experience. She treats patients of all ages in the outpatient, inpatient, and hospital settings. She cares for patients with eye trauma and common eye problems, such as blurred vision, glaucoma, strabismus, or lazy eyes and dry eyes. She performs eye surgery to repair tears to the eyelids, straighten eyes, lift eyelids, and remove eye lesions. She performs strabismus surgery, ptosis surgery, tear duct surgery, repair of corneal lacerations, and ruptured globe repairs. I'm sure she will explain what some of those things mean to us shortly. Dr. Akor has been a physician leader and educator throughout her career. She has served as chairwoman of the Department of Ophthalmology at the Hendrick Medical Center in Abilene, Texas. She served as assistant professor at the University of Texas at Houston and the University of South Carolina. And she regularly lectures residents at both the Driscoll Children's Hospital and Spahn Hospital System in Corpus Christi, Texas. And as you will see, she is a skilled communicator who is able to explain difficult medical concepts clearly. And she currently sees patients at her private practice in Corpus Christi, Texas. So go ahead, Dr. Akor, take it away.
Thank you, Amy. Thank you for the wonderful introduction. So this is the highlight of my talk. I want you to go away with these 5 facts. You understand the eye anatomy basics. You understand the common types of eye injuries. You understand visual acuity and how we explain impairment. You want to know what the long-term consequence of an injury is and the treatment, and where that expert witness and medical testimony comes into play when you're trying to get compensation for your patient. So, like Dr. Fogelman said, I've been a board certified ophthalmologist for 17 years. I currently reside in Texas and have multiple medical licenses. My current practice focuses on pediatric ophthalmology and ocular trauma, and I'm experienced in peer review, IME, and expert witness testimony. So my educational journey is a long one, but I wanted to take a moment to explain why eyes are difficult. So I did 4 years of undergrad at Yale College, 4 years of medical school, a year of research in ocular pathology. And you say, what's ocular pathology? It's when the eye is already in the jar. Like, what happened to that eye? Why did that eye die? I did a year of general adult medicine, 3 years of eye surgery training, and 1 year to specialize in children. So I want to make sure you have these eye anatomy basics. And if you have any questions, write them down, because this needs to be simple. You need to understand all the parts, the key parts of the eye that can get damaged in an injury incident. So I love this picture. The eye is an amazing structure, and half the eye parts you can see, right? So we can see this baby. I want you to focus in on the baby's eyes. And actually, you can't see the cornea. The cornea is the clear cap of the eye. Light has to go through that. When someone says, hey, I have blue eyes or I have green eyes, we're actually talking about the iris. The iris is the colored part of the eye, and it has a muscle that can make the pupil big or small. So that black space you see, it's actually the space between the iris, we call the pupil, and it can change in size to allow light to come inside the eye. And this baby is perfect. So when you're young, you're usually born with a clear lens. So right behind that black area is a clear lens. And so the lens of the eye is like a lens of a movie projector. So when you go to the movie, the lens of the movie projector places the image on the screen. In the case of the eye, the lens of the eye places the image on the retina, the back of the eye, the film, the screen of the eye. So this is just that same side view. So I talked to you about the cornea. So you can see it in the side view. It's nice and clear. It's supposed to be perfectly clear. And I'll show you some examples when it's not clear. This is the iris, the colored part of the eye. This is showing this iris is blue. That pupil is actually a empty space between the iris. And then there's that lens. And a baby, it's nice and clear. As people age, it gets cloudy, but that, when the light comes through, I'll show you, that helps project on the back of the eye. Now, the sclera is the white that you actually see. So the conjunctiva is a very thin white coat on the front of the eye. And then the sclera is the deep coat that goes all the way around the eye. And the eye is about the size of a ping pong ball. So can you imagine squeezing it? Sometimes that happens in the case of trauma, but that sclera is actually the coat of the eye, or the coat of the ping pong ball that we have. So here I want to focus on some of the structures in the back of the eye, and I'm going to show you a real live view. The retina is that film of the camera. So the image projects here on the retina. The optic nerve, the cord from the brain, it gives the signal of the image back to the brain. The macula is the sharpest part of the retina that gives you that sharp, crisp vision. And the back of the eye actually has blood vessels, arteries, and veins, but the front of the eye does not. So we talked about the front of the eye, this space here, it actually has nutrients floating in it to keep the lens nice and clear, to keep the cornea nice and clear. So this is just the schematic of the eyeball. And so this is a real live view. I always, when I look in a teenager's eye, I'm like, oh, to be a teenager, to have a perfect eye where they have the sharp, crisp macula, where they have all the cells to help you see very well. There's some here on the outside, the blood vessels, and then here's that optic nerve, it's brain tissue, and it relays the vision information to the brain. So here's some other critical parts of the eye. This is the lacrimal gland that makes tears to wash your eye. You also see the lashes. You can blink, right? So if somebody sees something going toward their eyes, they blink, they close their eye. That muscle is in the eyelid. And then this is the nasal lacrimal duct system where the tears drain out into the nose. And another thing I wanted you to be aware of, the eye sits in a socket. So think of this ping pong ball sitting in the socket, and there are bones in this socket to keep the eye protected, because it's a very, very important structure. So again, how does the eye work? Say you're looking at a light bulb, that image of the light bulb, passes through your cornea, the clear part of your eye. That image goes through the pupil, which is just the space between the iris, the colored part of the eye. That lens, it's a busy structure. It changes in size to focus the image on the back part of the eye, the macula. That's your film of your camera that helps you to see. And then that optic nerve, the cord from the brain, it's the messenger. It sends the message of what was seen to the brain. So what can happen to the eye? We just reviewed the anatomy, that perfect structure, but there are common type of eye injuries, and I'm going to focus on the common type of eye injuries in relationship to an auto accident. So if you have any question about any other injuries, I'm happy to talk to you about that. We're on a limited time schedule, so I'm going to talk about everything in relationship to, hey, what happened to the eye in relationship to someone had an automobile accident. So this is an eye. This is not like the pretty baby eye. Let's say this person actually had a pair of glasses on and the glasses were made out of glass. So when the person hit the airbag, the glass pieces broke and stabbed the person in the eye. The glass could have gone in and out of the eye, or possibly the glass could go all the way inside the eye. So that's the first thing. When a clinician sees a patient with an ocular injury, they have to take a history. So I'm giving you the history. Now, what can we tell objectively about this picture? Well, we learned about the structures of the eye. The cornea is supposed to be nice and clear. It's supposed to be a perfect dome, but this dome has a tear in it. It has a laceration. That's the medical term for the tear in that clear dome. And because that dome is deflated, you see the iris, the colored part of the eye coming out of that out of the eyeball. So that this patient has what we call a corneal scleral laceration, and some of the other things that your patient should be evaluated for in the emergency room is, well, one, when someone has a ruptured globe, this is corneal scleral laceration is a type of a ruptured globe or an open globe that the eye should not be pressed on. So the patient should have a shield blocking it, but there are other tests that should be done. There may be imaging. So if the face hit the airbag, they want to check to see if there are broken bones around the eye. They want to check to see, sometimes the imaging could show if there was something inside the eye, if there was a big concern of actually the foreign body being inside the eye. This type of injury may be transferred to someone we call a retinal ophthalmologist who has the skills and the talents to operate in the back of the eye. But if this injury happened and there was nothing inside the eye, someone like me, a general ophthalmologist, would do surgery on this patient, put the iris back in the eye, or cut it away if it couldn't be put completely inside the eye, and sew up the holes in the cornea. So that is an example of a corneal scleral laceration. Now this one looks a little bit more serious, right? So similar, another corneal scleral laceration. So it looks like someone had a tear in that beautiful clear dome. This person's dome is not clear and beautiful. It has a big scar across the center, and the colored part of the eye, the iris is plugging that wound. And sometimes when the colored part of the eye is damaged severely or shake severely, it can cause bleeding. So this person was driving down the street, eating with a fork. The fork cut their eye, and this is what we get. So what would happen next with this patient? Well, the shield would be put on the eye, and most likely this case or this surgery would be performed by a retinal surgeon, because there could be some damage in the back of the eye, and really, if it can be repaired at the time of the original injury, that would be great. So this is the outside of the eye. So these are our lids and lashes. They protect the globe. You can see that the patient has bruising. Uh, this person was hit with an airbag, and that's where the bruising around the eyelid came. Well, the question is there any eye damage? Well, it doesn't look like the eye has a tear or a rupture, but sometimes when the eye hits an object like an airbag, the eye is like a ball, so it can deflate and reinflate. So even though this person doesn't have a red eye, they can have something called what we call iritis, where there's inflammation of the iris, and it can cause light sensitivity. Sometimes swelling and redness around the eyelid is an indication that those bones around the eye are broken. And the back of the eye needs to be examined. So certain damages of the inside of the eye have to be detected early to really give a patient the prognosis on how their eye will recover. So here's another example. You can see this person, he could probably hit the airbag also. You can see he had some glasses on. You see the damage around his nose. And this patient could have had what we call an orbital fracture, tears around the bones, and um, uh, inflammation inside of the eyes. But another thing that I want to let you know about blunt trauma. So, an eye is supposed to stay like that ping pong ball. It's supposed to stay nice and round. But sometimes if it gets hit hard enough, um, it can have blood in the center of the eye. So this person got hit really hard. This person got hit so hard when the airbag hit them because they were dancing and singing and moving forward. And so it gave the airbag an extra chance to hit that eye really hard. And so that iris, the colored part of the eye, it ended up having some bleeding. And so what would happen in this case? The patient would go home with some medicine. The doctor would make sure the patient's eye pressure was in normal range. The patient would have to sit up with the head of the bed elevated so their body would absorb that blood. But the key is, or the next step is, what is happening in the back of the eye when an eye is supposed to be a ball? So when that ball deflates and reinflates, tons of things can happen. So this is another example of what we call a blunt injury, where it was an object, but the first ones, that was a sharp object that damaged the eye. This is the airbag. The blunt object hit the eye, but it hit the eye so hard that it caused bleeding. So I've seen patients like this that if the airbag hits the eye so hard that that lens, that clear part of the eye that's supposed to focus the image on the retina, it's in a capsule. And so that capsule, if the capsule is no longer intact, the lens turns completely white. So I've examined patients in the emergency room, and I can see that, well, I can see the back of their eye. I don't see any damage in the back of the eye because I can see through the clear lens. And then the next time they show up in my office and their eye is white. So that tells me that that bump, that airbag injury, that velocity that their eye was hit, it was hard enough to uh, to violate the capsule that goes around the lens and cause a cataract. So we hope in this case that this is this person's only injury. So when the lens and the cataract is removed, he or she can see well. I have two more slides of just injuries to share with you. So the first two were penetrating injuries where like glass or metal entered the eye. The rest were blunt injuries. The blunt injuries, the harder they get, the more damage you see. This is another blunt injury. It was so hard that the iris actually pulled off of its root, and it's not noted to be in its normal shape in the eye. When an eye gets hit this hard, it's often a clue that there's damage to the back of the eye. And so this is an example of an eye that was hit really hard. Think of that ping pong ball. It deflated and then it reflated, inflated, and so the coating of the eye, the retinas on the inside, that there's a big crack to the inner structures of the eye. And unfortunately, this crack is right near the macula, and that's responsible for the sharp seeing part of your eye. So when you think, oh, well, the eye was just hit by an airbag, or the eye was just hit by a ball, or the eye was just hit by a fist, it really depends on the velocity of the injury. If the eye inflates and deflates, how severe that trauma is to the eye can really affect how well the person can see. And those cells, I kind of call the retinal cells are rods and cones. I call them flowers. And so if trauma is like a frost, so the frost happens and those cells are damaged, and then they can't recover. So depending on the severity of what we call a blunt injury, the back of the eye is damaged. And even though the front of the eye can be fixed, so we can sew a cornea, we can replace a cornea, we can replace a lens, we haven't figured out how to replace the retina, the film of the camera, and we definitely don't know how to replace the optic nerve, the brain tissue that sends the signal to the eye. So sometimes if you get hit hard enough, that's called traumatic optic neuropathy, where just the cells are so stunned and so damaged. So this is very important, especially when you review records, or you have somebody review records and you want to have a very intelligent conversation with them. What is that visual acuity, and how is visual acuity measured or expressed with impairment? So when I go examine a patient in the emergency room, and I have an eye chart like that's on my phone. So I cover the patient's eye, I check the vision in one eye, and I check the vision in the other. So it's very important that an actual visual acuity is obtained. Now, when you go to the eye doctor's office, they check your vision at 20 feet. But still, those handheld charts are pretty accurate. So let me tell you a little bit about vision. So to get a driver's license, an unrestricted driver's license, your vision has to be 20/40 and better. This is at least in the state of Texas. To get a daylight driver's license, your eye has to be 20/70 and at least one of the eyes. And then 2200 is usually the consideration of legally blind. And some people have jobs where they're required to have binocular vision. They're required to have two eyes to do their job properly. And what do two eyes do for you? It allows depth perception. So making sure that the vision is obtained when the person has the injury, when they first make contact with the healthcare personnel, is very important. It can give us some information on the prognosis of the recovery. And then also, that patient that I showed you, the lens that was completely white, that person had good vision at when I initially examined him. And then if you check that same patient 3 days later, when the cataract formed, his vision would be 2400. But knowing that patient had good vision before the cataract happened actually means that the back of his eye may be pretty good. And that's the part of the eye we haven't been able to fix. And so it's important to know how visual acuity is assessed, and what type of vision each person needs to see well, to drive, to do their job. Again, it's usually tested with Snellen acuity. If it's a child that has a trauma, we may try pictures. And then there's a differentiation between total and partial loss of vision. So that optic nerve, that cord from the brain, that telephone cord, if part of it's damaged, you can lose part of your vision. And then once you determine your person's visual acuity, peripheral vision, the doctor or you can actually get an assessment on how it can affect their day-to-day activities, their ability to enter back into the job force. So having a visual acuity measurement is very important when you start with an ocular injury patient and person. Okay, so what are some of the long-term consequences when someone has an ocular injury? What are the potential complications? So you remember I showed you that picture of the eye that had all that blood in the center? Well, 3 days later, that can rebleed. So making sure the person is connected with the eye care personnel to have ongoing pressure checking, right? Making sure that patient doesn't uh, end up with glaucoma, so that you remember that colored brown iris that was no longer looking like the normal eye, that was pulled away from the eye. Now the angle where your intraocular fluid is supposed to go in and out, that person can have glaucoma. So actually being able to, one, be able to name the injury, blunt trauma causing glaucoma, blunt trauma causing a traumatic hyphema. That tells you how often, what are some of the things that can happen because of that injury. So blunt trauma can cause glaucoma, blunt trauma can cause um, um, chronic eye pain, inflammation, and light sensitivity. And then again, what are the risks of infection? What are the complications of the healing process? So the first eye, right, that had that tear in the cornea, that dome in the eye, because the cut or the laceration was laterally, when that eye is sewn up, it may, because the person has had surgery or because the eye is open, they're at increased risk of infection. And then while those sutures are in the eye, it can make that dome less smooth. So that person may have been someone who didn't need glasses, but because of the corneal tear and the stitches, they may need glasses to see better later. So all those things, eye injuries are very, very complicated, but making sure that your patient, your client, is aware of the ongoing risks and complications and are making sure that they're keeping with their eye visits during the healing process. So, who should you have as an expert witness when you have somebody who um, is has been in an auto accident and their orbit or their eye is damaged? I think the ophthalmologist is the best qualified to aid in these cases. And the reason why is because an ophthalmologist spends at least 3 years studying eye disease and preparing to do eye surgery. Some of those cases where I said, well, you may need a retina surgeon if the back of the eye is damaged, the macula's damaged, they actually do 1 year of general medicine, 3 years of eye surgery training, and 2 years of additional training to be an expert on the back of the eye. So having someone who sees patients with retinal damage frequently, who sees patients with glaucoma, who sees patients with trauma frequently, can really give you an accurate assessment of what can happen with your patient's eyes. So I hope I was able to explain some of these complex concepts to you, right? As we went for what part of the what each part of the eye was and how it can be damaged, and hopefully the next talk will be how it can be fixed. So you have to be able to explain, right? This is the eye in child's terms, and this is what broke. The ping pong ball, it got compressed, it came back to its normal size, but the inner layer of that ping pong ball got damaged. And that's what you saw in that picture, that retina that had the the yellow and the black. The eye's not supposed to change shapes that much. And then it's important to obtain clear and concise medical reporting for legal proceedings, right? What was that person's vision? What did that doctor see? How did he describe the iris? How did he describe the anterior chamber? Did he see any blood? Was the iris irregular? All this is important. When I do trauma cases, especially when there are tears in the eyelid, there are broken bones around the eye. I take pictures because sometimes people may have been drinking when they have an injury, so they remember themselves with their perfect selves, with their uninjured selves. And so having documentation with pictures, and pictures are so easy now to one, just have the pictures of the person's face, but when they follow up in the office, there are cameras that actually can take pictures of the retina and go really far out. So rather than just depending on a doctor's description of the retina, there's also a picture of the retina to allow it to be easier for people to understand. So I'm going to stop, Amy. I hope that was clear and concise, and I look forward to the questions.
That was great. Thank you so much. I really appreciate it, Charlotte. Before we go on to the attorney's questions, I actually have a question, which is just, I'm an internist. When I look at eye records, it seems to be in a different language to me. And this is different than pretty much any other specialty. I can read the records, but for eyes, I don't understand what it means. So are there any tips for lawyers who are doing these eye trauma cases when they're looking at the records, what they should be looking for, what types of, and any tips about what some of the records, the things they would look for in the records?
Well, sometimes, well, really, if they're looking at records when someone has a trauma, it actually depends on who's writing the records, right? So some emergency room doctors, so that's where a lot of the traumas end up. Some emergency room doctors will not give a visual acuity, and that's problematic, right? If someone says the person can count fingers, a count fingers vision can be anywhere from 20/40 to 2400, right? So that is quite problematic. So one is making sure there are not holes in your records. What is the visual acuity? And I don't know if some of the ER doctors are savvy enough because they're busy saving the person's whole life, right? When they call me, I just get to focus on the patient's eyes. Is, well, when a person's eyes are checked, did they have their glasses on?
Right.
So if someone is older and they need reading glasses and you're trying to do a near vision at the bedside, then that may not be very accurate. So so no, maybe they need a translator to read the records.
Fair enough.
But the problem is that there is, not saying no standard, but sometimes it's difficult when someone's in a trauma and they're checking a bunch of different things that they say, oh, well, the patient could have just seen my fingers, or, it's not clear. So when you read an ophthalmologist records from eyes, it'll say visual acuity. And then the ophthalmologists usually mark with or without glasses, right? And then they'll mark left or right. But ophthalmologists, we do use a lot of lingo, right? So
right. OS and OD.
So right and left, yes.
So
And then
explain what that means.
so the right eye is OD, the left eye is OS. And then we like a abbreviation. So L and L is lids and lashes. CONG is the conjunctiva. Actually, a big K means cornea. AC means anterior chamber, that space between the cornea and the lens. Sometimes you may see L or they may have a template that says lens, and then V is vitreous. So I didn't talk about that jelly part that's in front of the retina. That actually makes up 2/3 of the eye. So sometimes if the eyes hit hard enough that you can have blood in the vitreous. So MVP, macula, vitreous, and periphery. So I try to write it out on my very first assessment, but then if you look at some of my charts after, it may say MVP, right? You're like, oh no, the person wins. No, it's the macula vitreous in the periphery. So we're guilty, Amy, the ophthalmologist. We like to use a lot of uh, abbreviations to
Yeah.
document our work.
How often are you called to trauma cases? Like, is there a certain percentage that you are called to?
So it's standard of care. It may not have to be that night, but it's standard of care if someone has orbital fractures to know what the person's vision is, right? So I was taking care of a 7 or an 8-year-old that got hit with a baseball. And so uh they the plastic surgeon was asking me, well, hey, I'm thinking about taking this child to surgery to fix his broken bones around the face. What do you think, Charlotte? And so I went, saw the kid. The kid basically only saw the big E. His
Wow.
other eye was perfect. Um, Sometimes when that optic nerve, that telephone line to the brain is damaged, you may see what we call an afferent pupillary defect. It may not act properly. He didn't have that, right? So then I dilated the patient's eye, and his retina, that film of the camera was actually white. It was bruised, right? So it was bruised. So it's standard even if someone just suffers from the broken bones around the face to have a complete eye exam somewhere within 24 to 48 hours. And if, say, my colleague went and operated on that child, and then the child says, well, I can't see. Well, was it the baseball that hit the child's eye, or was it the surgeon's error, not error, but so a person should, it may not have to happen that night. So if one of those eyes where it looked pretty white, but the bruising around the eyelid, just so that patient gets an eye exam within 24 to 48 hours is reasonable. But obviously the eye with all that blood in and is one that the ophthalmologist should be called to the bedside, make some recommendations to evaluate the eye pressure. So if the person has really high eye pressure at the time of injury, it can basically, that high eye pressure can kill that optic nerve, the cord from the brain. And it doesn't matter if things heal and are fixed later. That acute elevated pressure for 2, 3, 4 hours could kill the brain tissue, the ability to see, that optic nerve, that telephone cord to the brain.
Okay. Is there ever a time when you would recommend using an optometrist rather than an ophthalmologist for cases? And can you explain the difference in training? You went into detail about an ophthalmologist, but what's the difference for?
So the optometrists or doctors of optometry, they do spend 4 years studying eye care. Uh, what you get when you are working with an ophthalmologist is a level of expertise. We're tested on the pathology. So uh, I'm not sure about what the optometry board exam, but the ophthalmologist, that's what we do. We do pathology. So maybe use an optometrist to help translate some of the lingo, but the person who takes care of eye trauma is the ophthalmologist. I don't know any optometrists who are taking emergency room call. So having the experience, you'll get the bang for your buck to say, hey, well, that isn't something that's very serious, that that doesn't have a long-term sequelae. Most of the time, 90% of the time, that person can heal without difficulty.
And I would just add that optometrists, they don't go to medical school, so
Correct.
they're not medical
Medical
doctors.
doctors, yes.
Um, that was a great overview of motor vehicle collision cases. What other eye injuries do you commonly see and do reviews on?
So uh, metallic foreign bodies.
Mm.
I recently took care of a young man who was at work working, and a bunch of cement flew in his eyes. So there were a lot of foreign bodies.
Mm.
I actually took care of a bus driver who was hit with a piece of glass on the side of his head so hard. I mean, just whatever trauma um, has happened, I've seen it. I was in academics at the University of Texas at Houston, and as the pediatric ophthalmologist who took care of most of the trauma cases, I saw Barbie doll hands that could stab eyes, similar to that first picture where the iris is peeking out, an Easter basket that can do it. I mean, it's just amazing. You want to have goggles on all the time to protect your eyes from any injury.
Okay. I would imagine like dog bites,
Dog
those
bites,
kinds of
yes.
things. You probably
Dog
see
bites.
that a lot.
The last corneal laceration repair was a kid that the cat
Oh,
came close to his face and cut his nice clear corneal dome. So
ugh,
that was the last surgery, emergent surgery I did.
okay. Um, what parts of the eye are prone to bleeding in an accident?
That anterior chamber, so that iris, there are blood vessels on the iris, and so when you saw blood in the front of the eye, that's the anterior chamber. And then the vitreous, the blood vessels from the retina, they can bleed in that space called the vitreous.
And is there something that the patient can do to prevent further damage when they have ocular injuries?
Yeah, so don't sneeze, don't bear down, and put some glasses on. When the patient is actually in the care of emergency personnel, they should get a shield on their eye. But sneezing, bearing down, if the eye is open, some more of the tissue can come out of the eye, and it's harder to put it back
Can you
in.
explain what a shield is? I don't understand that. Sorry.
So a shield is like an eye cup. So, but it doesn't come out as much as a cup, but
Hmm.
it's a little, it's plastic. Some are plastic, some are
Okay,
metallic,
got
but
it.
that just makes sure that um no one's no one's pressing on the eye,
Got it.
and nothing else can get inside the eye. So
Got it.
shielding the eye, protecting the eye is very important.
And I think we have time for one more question. If one eye has permanent damage, what can the patient do to protect the other eye?
They need to be wearing safety glasses all the time. So safety glasses are polycarbonate lenses. So I'm new to South Texas, and so the example I gave you was with a piece of glass. I ended up sewing up somebody that had glasses instead of
Oh,
polycarbonate or plastic glasses. So there are some parts of the world that still sell glasses. So it's very important that when a person has glasses, they have the appropriate type, they're polycarbonate. It's probably even better to have safety glasses where if they're doing something that it protects the side of their eye. So sometimes when people are welding or hammering metal, the metal can come in from the side of the glass. So just making sure the appropriate eyewear, and if they need glasses and they have glasses, they need to be polycarbonate.
thank you, Dr. Akor. You can see how great she is. At High Rock Experts, you have access to over 4,000 experts just like her to help with your cases. And you know, as an attorney, how crucial it is to find the right expert for your case. So please reach out to us if you need help finding an expert. We'll go the extra mile to find you the right one at no extra cost. So thank you everybody for being here. Thank you, Dr. Akor. You're wonderful, and I can see that you would just be just a stellar expert. Obviously, you can explain these very, very complex issues in a way that is really accessible for lay people. And definitely go to our LinkedIn page, the High Rock Experts LinkedIn page, to learn more and sign up for announcements. Next month, we will be hosting Dr. Lily Johnson, who's a vascular surgeon, who's going to be talking about the medical and surgical aspects of vein and artery legal cases.